Okay, welcome back. Again, as we talked about, we'll get into more of the finer details of not just inpatient record documentation requirements, but outpatient and physician office records. We'll talk a little bit about some of the data sets that are used. And again, please answer the questions that you see come up on screen. They'll really help you with your retention of this material. Let's have a look. Okay, we talked a little bit about the inpatient record, but some other things that you can expect to find in the contents of a hospital record would be an ambulance report, right? A emergency room report, and that would be true if a patient especially is admitted. Sometimes you'll see a direct link to the history and physical, which we'll talk about in just a moment. We'll also see as part of the inpatient hospital record, the discharge summary, which is basically an abstract of the patient's hospitalization. So it'll cover why the patient was admitted, summarize any procedures that were done, and so on. And then the history and physical. The history and physical is gotten a little bit interesting. Well, Joint Commission standards and the Medicare conditions for participation state that the history and physical, normally referred to as the H&P, must be performed and documented in the patient record within 24 hours after admission, including weekends and holidays, right? Well, what happens in the case of if a patient has an elective surgery, they do the history and physical, they work the patient up like a month before, and then schedule a patient for a hip replacement, bypass surgery, or what have you. Well, you can do that, and the history and physical still counts, but you have to review and update it and put it in the electronic health record within 24 hours after admission. And you can see a description and some examples of those documents on the patient history in table 6.4 in your text. So I'd strongly advise taking a look at that. And a physical exam basically is what it is. We don't just look at imaging and lab tests and what have you. The physician actually has a face-to-face encounter, goes through a review of systems, does an exam, describes the finding, documents it, and it becomes a physical exam. And you can see more of those documentation examples on a physical exam in table 6-4. Some of the things that other things that you'll see in an inpatient record include the term differential diagnosis. So in other words, do they have food poisoning or do they have an acute appendicitis, working one diagnosis versus the other? Sometimes they'll bring in a specialist, which results in a consultation and a consultation report. Most hospitals require that when a patient's in-house, a physician, either the hospitalist or the surgeon or both, need to visit the patient at least once a day and document their findings, and more often if indicated. You can see an example of a progress note on table 6-7. And then we get into other things, the integrated progress notes. Sometimes they're kind of combined, as you can see, the pathology report, right? So everybody who has surgery, a specimen's removed, it's sent to the pathology lab. They'll work it up, they'll describe what the specimen is, they'll prepare slides of it. That will result in a gross description and the microdiagnosis, right? So they can say cells strongly suggestive of metastatic endocarcinoma, what have you. Those are the types of things that you see in the pathology report. And you can see an example of that in figure 6-24. And then we have ancillary reports. They're all different types of things and described in table 6-8. And again, who can document in the hospital record? Well, anybody who's providing some sort of services. right? So we always think of it as just physicians and nurses, but actually might be inpatient PT, might be medical social worker, all these other different types of providers. Let's talk about surgery for a little bit. And surgery, we think we understand what it is, but it's always just a little bit more involved when we come into health information. We have to have an anesthesia record. And this is a Medicare and Joint Commission requirement that states that any intraoperative anesthesia record is maintained. We also have to do a post-anesthesia evaluation. So this means the recovery room. So it needs to be documented by the provider who administered the anesthetic no later than 48 hours after surgery and in accordance with state law. So each state may vary a little bit, but for the most part, they're all very similar, right? And then these are also reflected again in medical staff policies and procedures. The operative record, or called the op report, is completed by the surgeon and it documents what the condition was before surgery, describes the procedure during surgery, and then talks about what happened at the conclusion of it. So patient was admitted, appendectomy was performed, patient, talks about the history of it, the exam, the labs, all that. And then they'll get into appendix removed, sent to pathology, you know, uh, closed, describe what they closed the surgical field with and what the blood loss was. And you can see an example of that in figure 6-23. And then the PACU, post anesthesia care unit, the recovery room. This is basically evaluating after the procedure. So again, all that is the perioperative documentation requirements. Let's talk a little bit about OB and newborn, right? On the OB side of it, we have the antepartum, the neonatal, the prenatal, and the labor and delivery record, right, on the maternity side. On the newborn side, we have the newborn identification, we have the physical exam, APGAR scores, and then the newborn progress notes and any postpartum records. Now, again, this kind of ties into both administrative and clinical, if you will, where CMS has guidelines about what is a major procedure, what is a minor procedure, and what is an endoscopy. In other words, an exam that's done through a scope. They're kind of, endoscopies are carved out in a separate, distinct group by CMS, but major and minor procedures are looked at as minor is 5 minutes and less, or less than 5 minutes. Major is 5 minutes or more. And again, CMS uses these procedure codes and has status indicators next to each procedure codes to differentiate them. And again, I think in an earlier lecture, I mentioned that nothing happens in the hospital unless a physician orders it. So anything that's diagnostic, like a lab or an x-ray, anything that's therapeutic, like albuterol or oxygen, has to be ordered. And these could be telephone orders where providers in the office or at home and call something in and it's taken down, or a face-to-face verbal order, right? they're still orders. So instead of getting lost in the minutia of what's a verbal order, what's a telephone order, think of them all as orders. And Joint Commission also addresses these orders for medications. They have to be supported by a diagnosis, condition, or an indication. So in other words, if we're writing for, say, especially in the case of opioids, we need to say what the diagnosis is, right? Compound femur fracture, right? We don't just give medications to give them. We have to have a reason, especially in the case of opioids, right? So that is a Joint Commission standard. Each and every medication ordered has to be supported by either a diagnosis, a condition, or some other indication. And you can see more about physician orders in Table 6-6. And again, autopsies, just because the patient died doesn't mean that nothing is documented. The medical staff attempts to obtain autopsies in all cases of unusual deaths to pursue medical, legal, and educational interest. What that means is looking at what happens so we can provide better medical care. And the mechanism for documenting permission to perform an autopsy must be defined. So in other words, getting consent for autopsies is a big, big deal. Need to go through the proper process. That needs to be documented and reflected in the record. And there has to be a system for notifying the medical staff, specifically the attending, about an autopsy. And you can see an example of that in figures 6-30. Now let's talk about the outpatient record. Joint Commission standards state that by the third visit, the patient record of a patient who receives continuing ambulatory services, for example, physical therapy, must contain a summary list that documents a diagnosis, condition, significant operative and invasive procedures, adverse and allergic reactions, current long-term medications. In other words, this type is summary list, and we many times refer to this as the problem list. And what is this used for? Well, this is used in ambulatory records, the short stay records. It becomes part of the Uniform Ambulatory Care data set. And listed in the encounters and the ancillary service visit or occasion of visit. The physician office record, a lot of times you'll hear the term super bill. These are the things that the physician will mark off, right? And it's an encounter form. Basically, what was the chief complaint? What did they come in for, right? And this is in the physician's office record only. And then, as we talked about in the beginning, Medicare conditions of participation require hospitals to establish a medical record service that has administrative responsibility for all medical records. And everybody, inpatient and outpatient, has to have a unique medical record number and medical record. The Joint Commission standards and the condition of participation state that a history and physical must be performed and documented in the patient record within 24 hours after admission, regardless of whether it's a weekend, holiday, what have you. Then finally, the Joint Commission standards require medical records to be both including diagnostic and therapeutic orders, verbal orders, telephone orders that are authenticated by the responsible physician within a time frame specified by the facility. And normally those facility policies and procedures about that are based on state laws. Some other Joint Commission requirements. include for the emergency room record, what time they and date they arrived, how they arrived, and whether they left against medical advice, and what their final disposition was when they left at discharge. Joint Commission also requires pre-anesthesia or pre-sedation assessment and monitoring of patient if they give moderate or deep sedation. And then last thing I have for this video lecture is the pre-anesthesia evaluation note from the person who administers the anesthesia. Okay, that's all I have for you on this video lecture. Come back for the next one. We'll finish our discussion of these documentation requirements, specifically in terms of documentation integrity, data management, forms control, and other topics. We'll see you in a few, and we'll talk to you about those items coming up next.